Hello, all you cool cats and kittens. My name is Nina Ramdevich, and with my classmates Martita Garcia and Greg Fell, we present to you a postural and gait analysis of a C3C4 incomplete spinal cord injury patient.
Before we get right into the gait analysis, we're going to play a video of the patient as he takes a few steps with the aid of a physical therapist. Note that the therapist provides body weight support, stability, and facilitates the patient's gait pattern with corrective repositioning of the lower extremities.
Good, Jason. It's fantastic, Jason. I haven't seen you do that before.
By using a sagittal view for this postural analysis, we will be able to know compensatory strategies and deficits or impairments in the frontal plane. This plumb line should go through the following anatomical landmarks: through the external auditory meatus, through the acromion process, through the lumbar vertebral bodies, through the greater trochanter, anterior to the knee joint, and anterior to the ankle joint. As you can see here, there are many deficits in the image above, as only his lower extremities are actually in contact with the plumb.
By using a frontal view for this postural analysis, we will be able to note compensatory strategies and deficits or impairments in the sagittal plane. In our video, we did not have a straight-on anterior view. However, even with this plumb line, we are able to note some issues in his postural alignment. This plumb line should go straight through the nose, midline of the sternum, through the pubic symphysis, and land evenly in between each foot.
Now that we've addressed the patient's standing posture, we will move on to an analysis of his movements during each phase of gait.
Initial contact is known for the moment when the foot strikes the ground. The hip extensors are eccentrically controlling hip flexion, the quadriceps are eccentrically controlling knee flexion, and the pretibials are eccentrically controlling the ankle to remain in neutral. In this snapshot, we can see that he does not achieve the crucial event of heel first contact, and both his ankle and knee have excess degrees of movement. We can also see that his pelvis is rotated more than 5 degrees.
Loading response is when the body maintains forward momentum and has absorbed the shock from the initial contact, and the foot is now flat. The hip extensors and abductors are eccentrically controlling hip flexion. The quadriceps are eccentrically controlling knee flexion, and the pretibials are eccentrically controlling the forward momentum of the body to achieve ankle dorsiflexion. In this frame, we can see that he does not achieve any of the 3 critical events listed above. He does not have an upright posture from his head through his trunk. His pelvis is even more anteriorly rotated than the previous phase. He has increased hip flexion. He does, however, have the correct approximate knee flexion amount. As you can see, it is not controlled because the PT is blocking any more flexion using his own knee. And lastly, you can see that there is no anterior movement of his lower limb from the forward momentum of the step, which would cause the dorsiflexion at the ankle joint.
Mid-stance marks the first phase of single limb support, and the body should progress in a controlled manner over the foot. The hip abductors are concentrically maintaining a neutral hip position, and the quadriceps at the beginning of the phase are controlling slight knee flexion, and the calf is controlling slight dorsiflexion at the ankle. In the image above, we can see that the patient is achieving the critical event of tibial advancement. However, it is in a very uncontrolled manner, as you can see by him having his base of support well behind his center of mass. Additionally, his stance limb knee is locked out. He's using his ligaments in his joint to support his weight instead of his glutes, quads, and plantar flexors.
Terminal stance marks the moment when the body progresses past the forefoot. The hyperextension of the hip and the slight flexion of the knee are done so passively due to the momentum of the body continuing forward throughout ambulation. The ankle achieves dorsiflexion control by the calves. As you can see from the snapshot above, the patient's trunk and pelvis are so far forward that even though his stance leg is trailing behind his center of mass, his hip is still in a seemingly neutral position. The patient is exhibiting heel rise as well. You can see his foot is starting to come out of his shoe in the beginning. However, from the video clip, it is clear it is not controlled.
Pre-swing is when the weight shifts to the contralateral limb, the knee rapidly flexes while the forefoot remains on the floor. The adductors are concentrically controlling hip hyperextension while the knee maintains flexion, and the ankle maintains plantar flexion, both passively. As you can see in the picture above, our patient still has a forward trunk lean to his posture, and again returns into hip flexion. He does have sufficient knee flexion for this phase in order to achieve the critical event. And lastly, as you can see, he does not achieve sufficient ankle plantar flexion because he is still in dorsiflexion.
Initial swing occurs when the swing limb begins to advance past the stance limb, and the knee flexes to allow for the swing foot to clear the ground. The hip and knee flexors work concentrically to clear the foot. The knee must reach 55 degrees of flexion to clear the foot. The ankle should be returning to neutral to clear the big toe after push-off and pre-swing. In the snapshot shown here, the patient does not reach 55 degrees of knee flexion, nor does his foot clear the ground. In actuality, he maintained the same degree of knee flexion and ankle dorsiflexion as during pre-swing. In order to achieve forward advancement and foot clearance of the swing limb, he instead compensates through excess hip flexion, aided by lumbar thoracic extension, and maintains a dorsiflex position of the ankle.
Mid-swing is characterized by further advancement of the swing limb. As the knee quickly extends, the tibia should be perpendicular to the ground, the foot should remain clear of the ground, and the ankle should dorsiflex towards a more neutral position. The momentum created by the swing limb carries the body past the stance limb, returning the pelvis to a neutral position. Eccentric engagement of the hamstring muscles should occur towards the end of mid-swing to control and slow knee extension. In the snapshot shown here, the patient has maintained the same 45 degrees of knee flexion since the beginning of swing phase. To advance the swing limb, the patient has relied entirely on his compensatory strategy of increasing lumbar and thoracic extension and increasing hip flexion. As a result, the patient has not created any momentum with the advancement of the swing limb, resulting in no natural increase in knee extension. Now that the patient's foot has left the ground, the spasticity of his hip adductors and bilateral weakness of his hip abductors becomes evident. As demonstrated here, we see a classic Trendelenburg drop of his left hip due to the weakness of his right hip abductors. To further complicate this, the spasticity of his hip adductors and weakness in his left hip abductors causes swing limb to scissor in front of his stance limb.
Terminal swing is marked by continued knee extension as the leg reaches forward to achieve proper step length and to prepare for initial contact. Hip flexion is controlled eccentrically by the hamstrings. The knee extension, or 5 degrees of flexion, is controlled by the quadriceps, and the pretibials maintain the ankle in neutral. In the snapshot above, the patient does have almost enough hip flexion for this phase, but is severely lacking full knee extension, keeping him from achieving the critical event.
Now that we've gone through each phase of gait individually, we listed here the major gait impairments that we witness throughout the phases. These are very typical for someone with a spinal cord injury. Because our patient experienced an incomplete SCI, he has the potential to regain some degree of function and walking ability. Oftentimes, with spinal cord injuries, damaged nerve cells blocking signals from the brain to the muscle in the body can cause weakness and/or spasticity in the trunk, hips, legs, and feet. It can also disrupt signals for sensation, alter them, or create abnormal ones. All of these factors in this kind of injury lead to difficulty walking, which usually is the focus of therapy interventions. In order for this patient to regain functional gait, the three main impairments that we chose to start working on were hyperextension of his knee in the stance limb, foot drop during swing phase, and decreased step length in swing phase. Now we'll go on and address each one of those impairments specifically with our intended treatments.
The first gait impairment that we focused on was knee hyperextension and single limb support. We see that our patient relies on the screw-home mechanism of the knee during the mid-stance phase of gait, which we can attribute to a number of reasons, including weak quads, weak gastrocs, basically the lack of eccentric control, motor control deficits, and proprioception deficits. What was that, Joe?
Carol Basket. Yep, that lady that profits over 1 point.
No, Joe, I don't think she's an underlying cause, but thank you. The quadriceps fail to perform in the manner we expect in this phase of gait, and you begin to see it during loading response when the therapist blocks the patient's knee to prevent excessive knee flexion. Once a person's center of mass goes over their base of support in stance phase, it is up to the knee extensors concentrically in the beginning and the gastrocs eccentrically to control the knee flexion moment over the ground. When the extensors or gastrocs fail, we begin to see compensations due to weakness to preserve knee stability, including a forward trunk lean, which is what we saw in the video. Lack of proprioception and motor control can also lead to gait impairments. For instance, with the quad, since we have disrupted sensory pathways, that can make the brain interpret pain in that muscle, and then that will decrease or disrupt motor recruitment, resulting in the weakening of that quad muscle. For our first intervention to address the knee hyperextension, we looked at cycling training combined with functional electric stimulation, or FES. This study took 25 individuals with chronic ISCI of all levels and had them participate in an FES cycling program for a mean of 3 months as a part of an activity-based restorative intervention plan. They were matched by age, gender, injury level, severity, and duration of injury to 20 individuals in the control group who received range of motion and stretching therapy. In the methods portion of this study, we were given all the parameters for the FES unit, where the electrodes were placed. We know what speed the participants were cycling at, and we know that sessions were 45 to 60 minutes, 3 times a week for a mean of 29.5 months. So everyone kind of did their own amount. And as for the results, there were a lot of outcome measures, but I have highlighted in red the ones that apply to the gait impairment that we are trying to address. So in the results, we see that the functional E-stim group that had the cycling intervention as well, they saw a marked improvement in motor function compared to the control group, about 80%. Their average improvements in motor scores were 8 times that of the control group. And this is all mirrored in their composite motor sensory score, which is basically showing a positive effect on their overall neurological function compared to the control group, which only improved half as much as. We also see that the functional E-stim group had 36% greater improvement in their volumes of their anterior thigh compartment compared to the control group. And this was mirrored with their finding that strength values were significantly greater in the quadriceps compared to the control group. So this intervention would be appropriate for our patient because we could use it to hopefully diminish the severity of this gait impairment of the hyper knee extension by increasing his quad strength.
The second gait impairment that we focused on was foot drop during the swing phase. The patient's inability to dorsiflex his ankle against gravity results in him performing initial contact with the forefoot. As a result, he avoids active engagement of the glutes, hamstrings, and TFL during initial contact and loading response. When the patient lowers his swing limb and forefoot to the ground, it allows him to not have to achieve full knee extension and results in a shorter step length. This patient does not currently hyperextend his hip and terminal stance or pre-swing. But when he does achieve that milestone, inability to dorsiflex at his ankle will prevent clearance of the big toe. In this article, the researchers studied the individual and combined effects that functional electrical stimulation and ankle-foot orthoses have on incomplete spinal cord patients during ambulation. The use of an AFO maintains the ankle in a dorsiflex position. This limitation in range of motion is what allows for the foot clearance during swing phase of gait. However, it also may inhibit other functional activities such as transfers. The use of an FES device assists in foot clearance throughout swing phase of gait by stimulating the common peroneal nerve in the lower leg, which causes dorsiflexion of the ankle. The researchers examined 3 outcome measures: foot clearance, gait speed, and endurance. They measured gait speed and endurance through timed walks for distance. They measured height of foot clearance through an optoelectronic sensor that tracked the motion of the foot. The results of the study showed that the best improvement for foot clearance came from the use of functional electronic stimulation. The ankle foot orthosis provided no significant improvement. However, both gait speed and endurance were improved with the use of the AFO and the FES, with the best results achieved through the combined use of both assistive devices.
The third gait impairment that we focused on was the patient's decreased step length. This is a multi-factor issue. First, spasticity of the patient's hip adductors and internal rotators caused his swing limb to rapidly and uncontrollably shift in front of his stance limb during swing phase. In the video, the therapist had to block the patient's scissoring foot and forcibly shift it back into place for the patient to maintain proper alignment of the lower extremities from step to step. Additionally, weakness of the patient's hip abductors caused a hip drop on the swing side, demonstrating lack of control and stability in stance. The patient never achieved hip hyperextension to allow for push-off during pre-swing, thus preventing any momentum from carrying the swing limb forward and advancing towards taking a full-length step. These main compounding factors resulted in the patient compensating almost entirely with excess hip flexion to take a step forward. In order to address this complex issue, we found a study that incorporated treatment and improvements to multiple elements of gait training. In this study, the researchers compared conventional gait training over ground with gait training on a treadmill assisted by a bodyweight support harness. The treatment also included passive stretching, passive mobilizations, and the gait training was aided by manual contact guidance from the physical therapist to reinforce neuromuscular education and minimize the effects of spasticity. The study showed that while both groups of patients, the bodyweight supported treadmill training group and the overground training group, experienced improvements in gait outcomes, the greatest improvement in most of the measured outcomes occurred with bodyweight supported treadmill training. The treadmill training allowed for the patient to focus on proper control of the lower extremities under reduced weight. Then the training progressed towards adding more and more weight back onto the patient. Ultimately, this allowed for progressive strengthening and coordination of the muscles required for a normal gait pattern, increased control and stability of the leg and hip and stance, increased range of motion into hip extension, and increased step length. It's important to note that the overground training group still showed significant improvement with the overground gait training and neuromuscular re-education that was provided by the physical therapist. So even if you don't have bodyweight supported treadmill training at your clinic, this still is a good option if you do it in parallel bars to reduce spasticity and improve overall coordination in a gait patient. To conclude, our patient who suffered an incomplete spinal cord injury at the C3C4 level of the cervical vertebrae experienced a multitude of neuromuscular movement deficits which resulted in functional impairments and a decreased ability for him to ambulate independently. Physical therapy treatment must address and improve his gait impairments if he's ever going to progress towards walking on his own without the aid of a physical therapist. The 3 functional impairments we chose to treat were knee hyperextension in stance, foot drop and swing, and decreased step length of the swing limb. We chose to treat knee hyperextension, which could result from weak quads or gastrocs, with functional electrical stimulation plus cycling to increase quadriceps strength. We chose to treat foot drop, which could result from weak anterior tibialis or spastic gastrocs, with functional electrical stimulation plus an ankle-foot orthosis for immediate improvements to foot clearance and secondary gait outcomes. Finally, we chose to treat the patient's impaired step length, which could have been caused by spasticity and scissoring gait, weak glute med and max, and limited hip extension through bodyweight supported treadmill training with manual facilitation from a physical therapist to control spasticity, in order to achieve improvements to step length and hip extension range of motion and overall secondary gait outcomes. And this concludes our presentation. The references that we used are listed here. Thank you for listening.